think this is a treatment that actually has to feel right too, because there's an element that requires some trusting and surrendering to the process and to the medicine and kind of what we're offering. And so it might not be right for everybody. But I think those that come to our clinic, they are looking for something different.
Hello and welcome. We're so glad you're tuning into the Taking Good Care show. I'm Dr. Andrew Wong, based in Toronto, Canada.
And I'm Dr. David St. Arnaud, based in Edmonton, Canada. We're two practicing psychologists with over a decade of experience each, working in a variety of settings and supporting diverse populations.
Thanks for joining us. We hope you enjoyed today's episode. While we're both practicing psychologists, our podcast is intended purely for educational and entertainment purposes. It's not a substitute for professional mental health care or treatment. If you're in need of support, we strongly encourage you to reach out to a licensed mental health professional in your area.
All right, good morning.
Good morning.
Morning.
Looks like the sun is shining in Toronto.
It is. It's getting cooler. And I guess listeners may have heard a third voice there. So I'll let Dave take it away with the intros.
Sure. We are joined by Ms. Priya Bains, registered psychologist based in Edmonton. She's been practicing for nearly 20 years, mostly in private practice, helping people with trauma, depression, life challenges. Priya's trained at McGill University and is a certified Hakomi therapist specializing in somatic and mindfulness-based approaches. That's actually my connection with Priya. It goes a couple of years back to my training as a Hakomi therapist. And Priya was one of the assistants that was helping out with my cohort. So we go back there and actually stayed connected since then. So I am super thrilled to have her join us today. But the main reason we have her joining us today is her current, in the last couple of years, she's recently been involved in psychedelic-assisted therapy. And she's been working at an interdisciplinary clinic called Atma-Cena. That's ATMA space CENA in Edmonton. There's also a location in Calgary. This interdisciplinary clinic provides some innovative mental health treatments like psychedelic-assisted therapy, RTMS or transcranial magnetic stimulation, which was mentioned in the previous episode, and ketamine-assisted therapy. We're thrilled to have her on the show to share her insights on this growing field and what it might mean for mental health care in the future. Andrew and I were kind of chatting beforehand and both admitted that we know very little about this topic. So if you're listening and you don't really understand a lot of the words that were just said, hopefully over the course of this episode, Priya can help us better understand this new, very new area of mental health treatment. So welcome, Priya.
Thank you. I'm glad to be here.
Awesome. So for myself, Priya, as Dave mentioned, don't know very much about psychedelic-assisted therapy. I guess for me, my knowledge of it actually comes a little bit more from previous, maybe a client or two who will have told me that they tried it, whether it was at a formal clinic or not, I guess some people will experiment with that given what they might find online. I think because it's not really, I don't know if this is safe to say, but maybe because it's not in the mainstream of therapy, not a lot of us know about it. Even as clinicians, I think it's safe to say that many clinicians do not practice in this area. So I'm really excited to have you here to educate me on psychedelic-assisted therapy. It certainly does exist. And I think through this, perhaps it's, again, giving people another option to treat mental health issues.
Yeah, no, I think you're not alone in that, Andrew, in terms of for those of us that are like practicing clinicians, it's very new, but I think part of what's really cool about this is that in some ways, and this is maybe just more my opinion, I think that psychologists or therapy in particular has really been put outside of healthcare. And so, we operate sort of over here. some of our clients have psychiatrists or maybe have a GP that's tracking and following their medication. I know I'm guilty of this, and so maybe other therapists are as well, where I'm probably not doing a great job consulting with that psychiatrist and that therapist, or excuse me, GP, around how are the meds going, and like really collaborating. And so what's kind of cool about this opportunity is that like we're bringing kind of two worlds together that really have not worked this closely together. It's very much medical in the sense that we are working with medicine and managing symptoms, but then equally therapy. And so I think that was like the biggest learning curve for me is, the therapy piece, feeling competent and knowing how to do this, but like having to learn a whole new language. Like I'm, working at a medical clinic, and yet a medical clinic that values almost the therapy at probably 70% of the process, and so these two worlds coming together, I think the average psychologist, therapist, we're not in that landscape.
Yeah.
So I think that for most of us makes us a little uncomfortable because we're not often invited into that world, or we actually sometimes probably don't do our own job of like, connecting with the medical world to help facilitate for our clients, like full comprehensive care.
So if we're starting from the ground up, Priya, I have a question, and it really goes back to how you got interested in this field. Because
Mm-hmm.
so many of us, when we go into psychology, even for grad school or, we're thinking, okay, the type of therapy that we're thinking about is more of the traditional route. So I'm actually very interested on a personal level, how you got interested in this.
Yeah, good question. I guess the first part of it is probably started as early as my undergrad. So I have a little bit of a non-traditional undergrad in the sense that I have a BSc in psychology. So my whole undergraduate degree was neuropsychology. So I had to take all the brain courses and all the what happens in your brain when you're learning, what happens in your brain when you're memorizing, or behaviors are happening. So having a science undergrad in psychology, it was very brain heavy. And when I decided to go into counseling and graduated, you know, somatic work, especially somatic work that was really talking about what was happening in the brain. So my first sort of move into any therapeutic process was trauma work. And trauma was really emerging as it's not about the story. It's actually about the nervous system, like what has happened in the body. And when I started to realize that learning about trauma and the body was actually really learning about the brain, it was like those two worlds kind of came together. And I was like, ooh, I like this. So I think part of it was just like me and like really liking talking about the brain. But I also sort of realized that clients actually liked understanding as well. Like, of course, they want to have relief, but they also liked being able to understand what was actually happening to them, like physiologically. So that's kind of where my therapy career started, was in trauma. And then I went on to Hakomi, which again is a very somatic based type of work, which has more of its underpinnings in like development and a little bit like in psychodynamics. But what's really interesting about Hakomi is we work in non-ordinary states. We just evoke the non-ordinary state a little differently. We do it through mindfulness and really attuned tracking of sensations in the body, impulses, urges, gestures, but really we are evoking a non-ordinary state. And so, to be honest, like psychedelics felt like a continuation of what I was already doing. It was like, oh, I know how to like sit with people and help them track and notice. And I would say the vast majority of the clients that we're working with, because psychedelics is still considered second line treatment, there's an element of treatment resistance that comes in. So a lot of the clients we work with have an underbelly of trauma. So I got to kind of have my training with non-ordinary states through Hakomi, then trauma, and then medical, which is all about what's happening in the brain. So it just was like all of these things that just kind of came together. So it feels, even though it's so new, it felt very like second skin for me and felt very comfortable to take like a step towards. Yeah, so that's kind of how I landed there. It felt like a natural progression of what I was already learning and doing.
Yeah, I'm following you, and I'm like, that was not my experience. I can remember having a client about 4 years ago, and even with a lot of the similarities and the parallels with the Hakomi therapy, this client asked me about psychedelic treatment, and I was like, I don't know anything about this. As far as I know, these substances are still banned, they're still illegal. They're used or abused, and I was like, our college is never gonna never gonna let us kind of do this work. So I just basically wrote it off as some kind of a fringe trend that was happening. But now, like seeing you at this interdisciplinary clinic, like
Mhm.
doing this work, I'm really interested to kind of know, like, even how you explain it to clients that are curious about this. And there is much more information than there was 4 years ago.
Yeah,
Like, because I would love to have a different conversation with that same client now in
yeah.
terms of what it could offer or when it would be clinically indicated and things like that.
My practice was a long-term practice, and I'm talking like long-term, like my clients were in it. And I don't know if everyone's practice was like that, but there's sometimes this point where it just felt like you couldn't move the needle with clients, right? Like it's just like, oh, I've tried this, I've tried this, I've tried this tool. And we just couldn't get past something that felt very, very stuck. And sometimes I think that's especially true with trauma clients, clients that suffer from trauma. And so the way I like to explain the medicines is, right now, so to your point, we only have easy legal access to ketamine. So that's something that a psychiatrist or, at our clinic, the overseer is the psychiatrist, the medical director, but is ketamine because it's been legalized for a very long time. We're using it off label, and so this is one of those terms I had to learn as a psychologist, like what's off label, So that essentially means that it came into the market for a particular indication, which was like an anesthetic, but it's one of those medicines that actually has been researched and has been used in different dosing ranges for lots of indications. So there's tons of research around ketamine and sort of mental health conditions in different dosing ranges. So we had legal access to that. So this is kind of why it's considered second line treatment. It's still, we're playing around with those edges of like client autonomy. Sometimes clients don't want to have to go on an antidepressant or an anti-anxiety for 2 years before they're sort of eligible. Sometimes they just know, and so, but it is still right now considered. And often the clientele that is coming to us, they've tried all of that and they're still feeling like they're not making the progress that they want. So often the way I'm explaining it to clients is what these medicines do is they open up neural pathways in your brain that don't often communicate. So it's like if we think about neural pathways that are often, what we know about neurons, right? Like they wire together, they fire together. So now imagine it's like we've taken a snow globe and we've shook it up. And all of those like snowflakes are like bubbling around. That's the opportunity that we're working with as a psychologist is all of a sudden the work that we're doing while some of these medicines are online or when they're in that expanded state, it's like now that intervention is not fighting against something rigid. So it's really, I'm using like an expanded neurology to now pretty much do the therapy I'm trained to do. Like I'm still very much working in scope, not doing anything different. It's just the opportunity is the mind and the body can actually like soak it up a little differently. So that's how I explain it to clients.
That's so interesting. I know Dave's got a bunch of questions. I have a bunch of questions, right? Dave, I'll let you go first. Let's see where this takes us.
Well, maybe just piggybacking off of that, because I was looking at the website this morning and there is a little section that's like, oh, what is it called? Resources, Psychedelics 101. And it does kind of walk through some of the different like medicines that you're talking about, like psilocybin, MDMA, ketamine, and what they might be used for. And so that might be a nice place for people to also check out if they're more
Yeah.
interested in this area. And
Totally. And right now, again, so I guess I should kind of circle back. We do have legal access to psilocybin and MDMA, but because these are Schedule 1 medicines, the only way we get legal access is we actually have to go through an SAP process. So that's Special Access Program, which we have to apply to Health Canada. And it's a pretty cumbersome process, but we can apply to Health Canada on your behalf. We sort of know what they're going to reject and what they're going to accept. Like they're going to want to see you've trialed 2 or 3 classes of medicine, that you've trialed certain types of therapies. Again, it's considered sort of an option of almost like last resort. But we have had successful applications and we have used those medicines in our clinic where Health Canada will say yes, and they will allow us to use those medicines. So that's sort of our legal way that we do get access to those medicines, but it's not as simple as seeing our psychiatrist and the psychiatrist saying, yes, you're approved, and away we go in a couple weeks. This can take up to months to actually work with Health Canada and go back and forth, and not everybody gets approved. And so when we're working with Health Canada under that special access program, they only approve those medications under 2 indications. So MDMA, you have to be diagnosed with post-traumatic stress disorder, so PTSD. So that's the only indication that will qualify you to get MDMA, because that's the one that the most research has been done on, is PTSD and MDMA. And then with psilocybin, Health Canada will only allow access to it if you have been diagnosed with MDD, so major depressive disorder, or end of life distress. And again, those are the 2 indications that the most amount of research is on. So those ones are a little bit more narrow. With ketamine, there's a lot of indications, anything ranging from trauma, anxiety, depression, to, adjustments, transitions, like, really any forms of stuckness. I want to say that generally because I don't have all the medical, my brain sometimes doesn't work in sort of like the DSM languages, but lots of indications. So yes, I highly recommend go to the website, check it out. But essentially I like to think about it is like, have you been stuck? Have you gone on medication? Have you done therapy for a while, but it just feels like the needle isn't working, or you're not getting where you want to be? I think working with these medicines and allowing that expanded state and then putting in the therapy provides a different opportunity.
And Priya, as you were talking about the different medications and also Health Canada, I was just thinking about, some past clients who I've seen, and I can certainly understand sometimes, they've voiced their frustrations because, like you said, maybe many different types of therapies haven't worked in the past. Maybe other medications haven't helped in the past from a psychiatrist. And so they read up on psychedelic-assisted therapy and they're like, I want to give that a try. It sounds like it's promising. I think it can help me. Nothing else has helped. But then let's say they put in an application and it doesn't go through. And this is where I think the legalities of all of this gets a little bit muddy and blurry because they want to try it, they haven't been approved, and so now they may find ways to do it themselves.
Yeah, what I'm really realizing, and we want to be really careful when we're handling clients that, let's call them fragile because they're exhausted, they're tired, they've been stuck for a while. Sometimes going through this SAP process can actually be like traumatic in and of itself because, we're working back and forth. They get rejected. They want more information, like, tell us about this, and the whole time they're holding on to this hope that they're going to get access to something and then they might not. And unfortunately, there's beautiful advocacy agencies like Theracell, we kind of mentioned before offline, that are doing a lot of advocacy work with like the Supreme Court of Canada and like the health minister to really give people legal access. Because often what happens is these clients will go underground and they will find their own way because this has always actually been happening. We're just more aware of it now because now, there's more media coverage, there's legal clinics that are doing it. There has been an underground movement for years, multiple decades, and they've done really beautiful work. So there's lots to be learned from those practitioners. And there also could be harm, because there aren't regulations, there aren't standards of practice, there aren't, so it's really important for us, like people like me who have somehow just lucky enough to have the license to do this on ground, really want to like honor the people and the wisdom that they've been carrying for like way longer than I have, and have the expertise and competencies to be doing that. But, just like there's harms and people doing not so awesome things, even with licenses, that's also true in the underground. And so, again, I think you have to do your research. Like, I don't think we can really stop somebody, because it does happen. There are actually a lot of psychologists that do what's called harm reduction. And so they know that their client is going to go off and do the thing. And they go, okay, if you're going to go off and do the thing, I'm going to make sure that you're prepared really, really well. And they will work under what's called a harm reduction model. And so they may not necessarily provide the medicine. They might not even sit for the medicine, but they go, okay, well, I'm going to see you before, and I'm going to make sure that you consider all these things. And then I'm going to see you after, because I want to make sure we sort of integrate this well. So that's also another stream that exists. Some psychologists feel so strongly about it in provinces where there aren't any regulation. They will also sit for medicine. They will not provide the medicine, but somebody might bring it with them in their own pockets, and they will sit for them in what is called harm reduction and feel very comfortable doing that. So there's a lot of nuances with this. And, I guess it's really about you as a professional, and also you as a client, or the general, like where do you want to fit in the spectrum? Because it does exist in all of these layers. So underground, harm reduction, regulated clinic, you can sort of find it everywhere. I guess it's just a matter of like where your choice point is, risk tolerances, comfort is.
I think this might be one of our more controversial episodes so far, right? Like, as I'm listening to you, you're talking about harm reduction, even calling like psilocybin and MDMA medicine. Some people will say, well, no, that's ecstasy and that's magic mushrooms. And those are, contraband substances that we need to make sure don't get in the hands of people. And so this whole like war on drugs and say no to drugs, this abstinence model that has been around for a very long time. And now it's like, even I have some like retired RCMP or active RCMP members, right, that are, their job has been to remove these substances from the public. And in their mind, these are drugs, these are harmful substances. And so it's really hard on our brain to make sense of this, right? Like, is this a medicine, or is this a psychoactive drug that is going to ruin my life or my child's life, right? And so I think we just need to keep having this conversation and looking at the evidence to say, when can these mood-altering, mind-altering substances be beneficial for human growth and healing, and when are they harmful? So I'm sure you must get a lot of these questions and comments at your office, at your clinic.
Yeah, I mean, I think those that end up on our doorstep are there for a reason. Like, they're very open-minded to it. Most people have actually not tried any psychedelic substances, but they're exhausted. They have tried all the things. And then there's ones that have done it recreationally. But I also went through that transition. Like, I knew the work made sense. The opinions around the work was, even I had that wobble of changing my language from drugs to medicine. And, so to your point, like, if we follow the research was happening in the 70s, in the 60s. It started actually in Canada. And a lot of it was happening in the States. Like, psychiatry was researching these medicines because they were finding benefits to their patients. And yet, when the Nixon administration happened and the war on drugs, like, a socio-political decision was made about these drugs. And so it was banned. Research was no longer possible. So you can follow the research. It shuts down basically in around 1971, 1972, and really just resurged in the last maybe 10 years. And, all of a sudden, You've got big institutes like Johns Hopkins funding research about psychedelics. So we lost almost 30 years of momentum on what these medicines, these drugs could have been in psychiatry and mental health. And again, we don't know, but again, there's something to say about our clients come in for like 4 treatments. I'm not saying they're healed, but they come in 4 times and there's substantial difference. And they come in for 2 psilocybin treatments or 3 MDMA treatments. I mean, this is not take a pill every single day for the rest of your life. This isn't be in therapy for 5 to 7 years like a lot of my clients were. Like it moves a little faster. And I want to be really careful that we're not selling a dream here. It's not like a panacea. It's not like you have to do the work, but I'm just saying it's a very different ideology than the one that I grew up in, based on like my age and what was happening kind of in that socio-cultural time of, the fried egg and this is your brain on drugs and all of that, to also like when I entered the field of psychology, right? And, kind of where, so it is like you have to be possibly open-minded. I think it takes a certain kind of professional. It's not going to fit for everybody. Like I said, I felt like this was it felt like, of course I'm going to go into psychedelics. Like I feel like I'm already on this like edge of doing it anyways. Like, let's just make it even easier. So I think it takes a certain kind of professional, because often when you're sitting with some of these medicines, like, with ketamine or psilocybin, you're not doing therapy. I'm not talking, I'm holding space because something is happening on the inside, no differently than if I was evoking mindfulness or a non-ordinary state with Hakomi. 10 minutes could go by and I don't say a thing because I know something is happening. I'm tracking that they're with something. So for me, it felt a little bit easier to stay quiet from 10 minutes. Now sometimes I'm quiet for 30 minutes. And I'm just observing the body doing what it's doing. I'm observing that they're being with something. And so if you're a CBT therapist, that might be really difficult, because you're not talking for sometimes large periods of time. Yeah. And there's a spiritual element that, again, the Hakomi world does really well. We braid in spirituality, I think, which a lot of people feel like is very true with some of these psychedelic medicines. So again, I think you have to be really open to who you are as a practitioner. And is this like a space that feels right with like my value system and how I want to work?
So, Priya, how does your clinic sort of assess for whether or not somebody is good for this kind of therapy? I'm sure, the clinic receives tons of referrals, but at the same time, I'm assuming that you can't help everybody. And perhaps there are some people who are not a great fit. So in terms of, someone coming in, what are there certain factors that you can share that your clinicians will look for when they're doing that first assessment, whether or not to even apply with the government to do this?
Yeah. So maybe I'll talk about the ketamine stream because that's
Sure.
the one that's like the main kind of one that most clients are coming in for. So first is you need a referral, right? So we are a medical clinic where a medical director is a psychiatrist. Just like if you were to see a psychiatrist, probably in any other fashion, you can't just make an appointment. You actually have to be referred to the clinic. So referrals often come from psychologists. So your psychologist will refer you to our clinic or your GP will refer you to our clinic. So that's the first thing, is that to some degree, you've already been screened by a professional who you have a relationship with. So that's the first step. Once they come into our clinic and the referral is sort of accepted, then they go into what's called an information call if they're interested. But it's basically a 10 to 15 minute call with one of our nurses just about our program. This is the way our program works. People have questions about costing, the process, the length, general kind of stuff. The main thing that happens after that is if they are They feel like, yes, I really want to do this. They will go through what's called a discovery call. So a discovery call is usually done by one of our nurses, sometimes a nurse practitioner. And essentially they're doing a full kind of history and almost like going through any contraindications for the treatment. Are they on any sort of medications that might interfere? The nice thing about ketamine is that most clients do not have to come off of any medications to also do ketamine. It works on a different receptor than the average psychotropic medicine, which often is more on the SSRI and sort of like the receptor is. I learned this in one of my classes, but I forgot the name of the receptor, but it can't bind. And so often clients don't really have to hold very much or come off or titrate off with ketamine. So they're looking for stuff like that. They're looking for, again, because we are a medical clinic, like we can go on Netcare and check out like, is there a history with a heart condition? Do we want an updated ECG? Do we we really want to make sure that like people are healthy, that they are, that, in some ways, sometimes psychedelic medicines can be kind of destabilizing because we're opening up a lot. We're, making things sometimes potentially confusing. So regulation, like, are they stable enough to be destabilized? And then have the skills to kind of bring themselves back. So we're kind of looking for all of that from a medical side. Once they pass all of the medical kind of screening and they're kind of, there's no contraindications, then they would meet with one of our GPs in consultation with the psychiatrist. And so they would get a full psychiatric assessment. So they would go through history, they would go through medication history, but, any trauma history, family of origin, like it's a full extensive psychiatric assessment, usually lasting about 90 minutes. And then the psychiatrist would make a decision pretty quickly after, within a couple of days, to say, yes, I feel comfortable enough to take this patient, this person on as a client of our clinic. So, again, as a medical director, which again is our psychiatrist, they take full liability for these clients. And so ultimately it's them determining that they are eligible for this type of treatment. Sometimes there's special considerations they'll put into the kind of chart, meaning I think this person can qualify, but they need 2 months of therapy before they need extra preparation. The stability is not quite there. They need to work with one of our psychologists. Or, maybe they're abusing alcohol and they say, well, they have to abstain for 2 months prior to eligibility for this. Or they're abusing cannabis. Okay, that has to titrate down. So there's all of that they're assessing for. And then it's not always a no, but it could be a not yet. And here are the things that we really need to see before we start treatment with you.
Is that an important consideration, Priya, in terms of previous drug abuse or addictions? And again, I'm coming from a place of perhaps ignorance, naivete, but, is that a strong consideration when doing that assessment?
Not always. I mean, we know that ketamine is a substance that can be abused. We do definitely know that. So it's taken into consideration. I did work with a client who had, a very substantial history of substance abuse with alcohol, but had been sober and was really worried himself about liking it too much. And then they go through the experience and they're like, man, there's nothing to like about it because it's hard. Like we are taking them to hard places while using the substance. But again, it's really remembering kind of what we're using these for. Like it's not just meant to be a trip. Like we are going and we're going towards trauma and we're going towards your darkness and we're going, like we are using them very intentionally. It's not just about like, here, let's kind of give you the injection and like enjoy the ride. Like for a lot of clients, it's not fun. And so I remember like very great, like I remember him coming back going like, yeah, there's nothing fun about it. And then his fear of like, am I gonna relapse? Is this something that I'm gonna enjoy? And it was like, no, he was like, no, there's nothing fun. So it's a consideration, but it's a very light consideration. I think there's more abuse potential when you have psychiatrists that are sending clients home with at-home use of ketamine Our clinic right now has not, like, that's not a part of our dosing. It's not a part of any of our protocols. So they come to the clinic, medicine is administered, and that's it.
You mentioned trip, and oh, it takes me back to like grade, I don't know, 10, 9. And I remember playing soccer with this kid. Or I was a kid too, but we were young, and he was experimenting with drugs, right? And he had taken some magic mushrooms, so some psilocybin, at a party and had a terrible trip, right? Like he was, it was potentially traumatizing. Like, and I can just imagine, right? Like the support that you would provide in this setting, because if someone has a negative experience like that, that can be re-traumatizing, right? They're left in a state where they feel afraid or like, they're going to die, or like it could be very scary. And so the opposite, though, if you go into your trauma, if you revisit something and you're supported and you're kind of cared for in a way that helps you know that you are safe, that you're okay, it can be really healing, like any trauma work that we do, right?
Totally.
So,
Yeah,
yeah.
and all of that is huge. Like, I mean, you would know this, David, because with Hakomi, we spend so much time just setting up the start.
Mhm.
Like, oh, like, how is this distance? Do we want to dim the lights? Do you need a cushion? You seem a little chilly. Can I give you a blanket? All of that is really to help create a sense of safety and comfort before we go inward and actually start to kind of dig at the work and go into the trough of the work. But we take a lot of time and consideration to the setup. The same is true in psychedelics, the playlist, the music that's playing is very carefully curated. What scent do you want to have in the room? They get to choose. What room actually do you want to be in? Like, I actually walk clients through all of our medicine rooms. Which one is calling to you? Do you like the artwork on this one? Do you not? Where do you want the nurse to be, in relation to you? So you go on some drugs and you go hit up a party and there's loud music and there's chaos and they're like, I can't even imagine how triggering that would be. And, so there's careful consideration to everything that is brought into the room. Clients have the option to, be in a recliner or be on the ground, weighted blanket, no weighted blanket, bolsters, pillows, some bring in their own blankets, objects. Like, there's so much consideration done to just the environment and the setting.
I love what you're saying because it's creating that safety and comfort, but also treating the person with dignity. Because I can only imagine, and correct me if I'm wrong, but if someone were to tell just a layperson, I'm going to psychedelic assisted therapy. I use ketamine there. I use psilocybin. Oh, what's psilocybin? Magic mushrooms. Like, I can only imagine that there could be stigma attached to somebody who's quote unquote using drugs for therapy. So,
Yeah.
I love how it contradicts that in the sense that you're treating the person with dignity. They're not seen as an addict, obviously, and they're not seen as a marginalized population.
No, I feel so grateful to have had this opportunity. Like, if you've ever been in a hospital and have had the privilege to work with a really loving nurse,
Mm.
like, what that level of care is like. Like, they have a job to do and they will do that well and they work within their competencies. But there's this extra level of like genuine, like loving care. That's what all of our nurses are just amazing. And if all you need is for someone to hold your hand, that is all they are going to sit there and do. Like, it's this like, so I love the word dignity, and I probably haven't used that language myself, but like, when our clients come into our clinic and then especially into the medicine room, like, the amount of like loving care that they are going to get from every person that they're in contact with, from the nurse to the psychologist to sometimes we have compassionate witnesses that come in just to hold space. And literally, like, even in the word compassionate witnessing, they are just there to tend to you and witness what's, a hard experience or could be a beautiful experience, but all they're going to do is literally with their presence, add to that energetic field and space and room, like, I'm rooting for you. I hope this goes well. And like all of those pieces, again, I think add to the setting, which really invites the mind to open up to the possibility that maybe it's okay for me to go somewhere hard.
Yeah. And I think, maybe for some of the listeners that had recreationally tried some of this and had a bad trip or a terrible experience, I'm curious what that looks like in your office. Like if someone is really struggling, that they're distressed by the experience they're having, what might like a therapist or someone, a nurse, what would they do to help support someone?
Yeah, so I mean, part of it could be like if it looks like they're visibly distressed. So I'm going to use the example of like psychedelic ketamine dosing. So this is where a client often, when you're in that psychedelic range, there's a level of dissociation that can almost happen with your physical body. So often clients can't feel like they can verbalize. So they're sort of in somewhat of a dissociative state, a psychedelic realm, but we can see from their body. So sometimes people are very verbal. Again, every client is so different. Sometimes they're not. You can tell they're, squeezing their body. They're, kind of tense. They're writhing in their chair. So again, with all the consents that we would have done prior, we go through consent around touch. Can we adjust your pillow? Can we add a blanket? So all of this has been pre-negotiated, and I would often pre-negotiate some of that too. Like, what's the non-verbal gesture that you're going to say? Like, I need a hand, or I need something. So often, just because it can feel almost overwhelming in there, it may be a little scary because it kind of feels like you're in it alone. Sometimes just contact, like physical contact, is enough. Sometimes we might really kind of get them nice and cozy and like tuck that weighted blanket around them. So again, there's a little bit of that regulation that comes back in. The body is fine. And sometimes we might even be verbalizing that, right? We might say, you're safe. You're not alone. I'm here with you. Sometimes that's enough. And people kind of can get over the wobble and get back into the experience, or whatever was scary for that moment. They can kind of get back into the next part of what needed to happen, but again, because we are like an authorized or licensed medical clinic, we have also what's called rescue medication, right? If we really if somebody is not okay and they're like, I'm not okay, like I need this to end, we do have, medications that our nurses are kind of authorized to use to bring somebody out of the experience. So that would be kind of worst case scenario. But again, sort of a little bit of the luxury. And, I'm not saying they don't do that in the underground, but like we are set up to administer and, we have access to all of that. But often, sometimes you have to go through the wobble. And so the nurses and the therapists are really trained to be alongside the struggle and let it ride out a little bit. Kind of, again, you'll know this terminology through Hakomi. We talk about riding the rapids with clients, and it's this kind of like real intensity of emotion and real intensity of sensation. And really our job is to be like, I'm right here with you. Just let it come through. Just keep staying with it. And it's kind of that, like we're riding some kind of rapid, and then it kind of settles, and then we allow the body to settle. And so again, all of us in this space would be sort of trained for things to get a bit wobbly without feeling uncomfortable ourselves and being like, oh my God, like let's get them out of this. They're not okay. So yeah, so again, we sort of have our ways to just be with them, I would say, in it.
And so while we're talking about the process, I am wondering how many sessions does this usually last for a client or a patient, and how long in duration, like all of those things before we may see some improvement.
So the average client is approved for 4 to 8 psycholytic or psychedelic ketamine treatment sessions. So I guess that's one thing that I didn't name. We actually have 2 different types of ketamine that we do. So the psycholytic dosing is a lower dose that's delivered through a sublingual tab. And it puts enough ketamine in the system that clients feel like their defense mechanism has softened. and they're feeling a little altered, usually not too altered, but they're feeling open, they're feeling kind of more soft, they're feeling more available to do the work. And then there would be actually a 2 hour therapy session that would happen while under the influence. So that's one. And then the other is our psychedelic ketamine, where this is often done with a nurse. It's a IM, so intramuscular injection of a certain dose. And often in those ones, it's a very internal experience. Like they sort of blast off into, kind of their own, wherever their mind wants to take them. But we are there just often. The therapist is not often in those sessions because it's a lot more of a quieter experience. They are kind of going through whatever. But the therapist bookends it. So they have seen them right up to the medicine, and they'll often see them after the medicine as like an integration session. So any combination of those two, I would say the average client is going 4, 6, 8, depending on what feels where they're at. I would say the average client stops at 4. And when I say stops, meaning either they feel really complete and they feel like they've gotten a big piece out of the way, or they will pause for 4 at 4. And it feels like there's enough that's come forward and enough pieces that they have to now integrate and actually like make sense of and work on and practice, that they might take a break. And so often that's when they're being referred back to their own therapist, or they might continue working with a therapist that was kind of working with them through the medicine. And they might do just general therapy for a few months before they're like, okay, kind of feels like we work, and oh, here's that other stuck place again, and I can't seem to get past that. And then we might bring them back into another round of some medicine.
Sorry, Dave, I know I'm asking a lot of questions here. Just one more to piggyback on what Priya was saying. So is there a point in time, though, that when you or another clinician will say, okay, this isn't working? Or is that too much of a loaded question?
Well, yeah, I mean, there are clients where, again, it's new. So a part of me wants to say there's probably not enough data, at least like in my clinical expertise. If I had, 10 years of client care under me, then yes, maybe I would say yes. But there are clients that can leave our program, like in full honesty, that are kind of like, I was hoping for more. I was hoping for a bigger change. I thought I was going to be healed. I thought like there's all of that. And so, yeah, like, can disappointment be a part of the package? Absolutely. Because often when they are at our clinic, it's because other things have failed. And so part of it is some expectation management that, as much as we are working with neuroplasticity and we were opening up expanded states, you still have to do the work, right? Like this isn't just the therapy, right? Then there's ongoing therapy. And that it's, there is a lot of integration and just therapy that continues to kind of keep happening. It's just the possibilities of change get slightly easier. Right. So has it not worked? I think I wouldn't say no, but I would say probably not as much as some of clients were wishing they would have landed after the treatment. And there's, I think, a variety of factors as to why that is. But I would say the biggest push that we really talk about is the work. There's the medicine, and then there's the actual work. And the medicine isn't necessarily the work. The medicine is just opening things up. And when we're doing some of that low dose, yes, the work is happening while the medicine is online. But then there's still all the work. Like, how are those pieces going to land? Like, what are you going to do with net? What do you know now? Like, no different than, we're giving our clients homework, or we're saying like, no, I actually don't think we should see each other next week. You need time to like process this. So it's very similar in psychedelic work. Is there's work between sessions.
So now I'm going to jump in, Andrew, before you ask more questions.
I'm not saying anything.
And Priya, yeah, maybe grab a drink, or, like we've been rapid firing questions, just conscious of time too, right? There's a lot to learn and a lot to know. And as Andrew asks a question, then I got 5 more. And so I do have 2. I want to make sure that I get to at least these 2, but just adding to what Andrew was saying, in terms of some of the research with ketamine that I've seen is that like it's quite promising, and there's a lot of almost like dramatic results that can happen quite quickly for clients. But the research still, and we're still learning, but like it's not as long lasting as some people thought, right? So, in terms of coming back for like a top up treatment, and I know you haven't been at the clinic forever, but like, have you seen that in terms of like people make some pretty big changes and they're doing the work, and then, 6 months, a year, or I'm curious what that looks like.
Yeah, I think that's a great question. And yes, absolutely. We have clients that will do their initial treatment 4, 6, 8. The average is between 4 and 6. I think we don't have too many eights, but 4 and 6, where they're feeling like, oh man, things are different. And then they just need to do ordinary life, like with that. And we do have clients that will show up anywhere between 6 to 12 months and kind of be like, I kind of feel like I need one more, or maybe like two more. Just sometimes it's to go back to, where they were. Because, change sometimes, if you're not fully integrating it or you're not fully walking the walk every single day, it sort of loses. So sometimes it's just like, oh yeah, okay, I forgot that point, and we're kind of reintroducing that. Sometimes it's because another piece of work has now emerged, right? What we know is like we clear one piece away and then sort of the other piece emerges. And that's especially true with trauma work because we have to do the work titrated. And so, as we did really significant work, and then now the nervous system has room for something else to like vibrate in there. And it's like, oh, here's the next layer of that. So yeah, I think we do, not everyone, not nobody, but somewhere in between. Like, I don't know what that percentage would be. I kind of want to say like 50 to 60% of our clients do come back for some form of maintenance. And part of that is, part of it could be because they actually feel like they need it. But part of it is they actually often feel like really good in our care. They actually feel like they got such good care that, just no different than all of us have clients that kind of disappear and then all of a sudden they come back because they're just like, oh yeah, it might be to pick up where they left off, but part of it is just like, oh yeah, I forgot how good this feels. There's some version of that too, right? Like we're not going to take them through another full treatment protocol because they don't need it, but they can definitely come in for like one or two and kind of see where that takes them.
Thanks. Yeah. And the other question, you mentioned cost a little bit. And because this is, you're working within the medical system and people are being referred by a GP or someone, is this private or is some of this covered through the public health care?
Yeah, unfortunately, it's pretty much predominantly private. So, right now, healthcare, there isn't any billing codes for psychedelics. So, it's right now like the nursing time can't be billed, the psychiatrist time can't be billed because there's no code for that. But can there can be a little bit of relief for some people who have like private health insurance. So no different than how they would cover our services in private practice. So if you do have coverage, you can cover the therapist time, which I would say is the bulk of the cost and the bulk of the hours, right? We kind of sometimes are the most expensive practitioner that's involved in this care. And so if you have coverage, then that can definitely be billed. But otherwise, yes, this is basically a private treatment. Public health does it as well. Like people do get ketamine treatments in hospitals, sometimes as outpatient, but this is a private medical clinic. So that's kind of where we're at right now.
So just the point to clarify then. So even though people have to get this cleared by Health Canada, they can be cleared to go through this therapy, but it's not covered.
Correct.
Oh, okay.
Yeah.
And just for listeners around the world outside of Canada, Canada's healthcare, if you didn't know, it is publicly funded for the most part. And so this is why we're sort of curious about this type of therapy and whether or not it's covered.
Yeah. So I think the biggest thing is when, even though Health Canada is the one providing, what they're providing is the medicine. They're not providing any of the services. Like they're saying, yes, this person, and when you fill in the application to Health Canada, we only actually give the client's initials. They actually don't know who this client is, who it's going to. All they know is that this is a psychiatrist who has put in an application, and this psychiatrist the application will get approved. They'll hook you up with a pharmaceutical company. The pharmaceutical company will directly send the medicine to the clinic or under the psychiatrist's care, but they actually don't know who it's going to. So from, again, a billing perspective, like, we're not billing under anybody's healthcare card because they don't know who's getting it. So that's part of it. But yes, so that's actually, I never even thought about it that way, but you're right. Health Canada is the one approving the medicine, but they're actually not dictating the terms in which we give them the medicine. So we are following the research and we're saying, well, MDMA, this is the protocol for MDMA. You do 3 prep sessions, you have a medicine session, and you do 3 integration sessions, because that's what the research says is the most indicative for working with PTSD. Health Canada is not dictating that. They're just saying, here's 3 doses, because that's what you applied for, and we applied for it based on the research. Just make sure it's locked up and safe.
Ah, okay.
Yeah.
Sorry, I'm shaking my head because I'm thinking, like, if you had cancer and you had to get your chemotherapy approved by Health Canada because you needed it, but then all of the care from the nursing staff or physician staff wasn't covered, that you had to, like, I think, the more and more evidence that comes out, the more it'll make a case that this would be an investment of, resources or funds from the healthcare system, because we know even with depression, it's one of the leading causes for absenteeism from work, and it affects a lot of areas of the community, of taxpayers' dollars, right? Like, it's healthcare. I think there's always a bit of a challenge in terms of what gets covered and what doesn't, and you are definitely in the area of this new new treatment that. Yeah.
Totally. And that's the thing. We almost, like, me as a clinician and anybody, any of our interdisciplinary partners that are involved in this, like, there's this, like, nimbleness that you have to be comfortable with, because rules keep changing. I really think in the next 3, 5, 7 years, like, it's going to be very different. So how I'm working with these medicines today might be very different 3 years from now. If they get approved, like, maybe we can be like, well, you seem like a good fit for this, or maybe we're going to do this and add this. Like, I mean, who knows? But I think that makes it kind of exciting for me, and that might be more a personality thing for me. I think it makes it really exciting. But the work is it's intimate. It's very intimate work. Like, you are bringing people to a high level of vulnerability, to some really hard places. And yeah, there's a level of intimacy that I feel very privileged to kind of sit alongside with.
Priya, with that level of gatekeeping that you just talked about, like, Health Canada approves it, then you have to find your own therapist. Like, to me, it still sounds like there's a lot of gatekeeping going on, and that possibly can, still promote a bit of that stigma, like, oh, it's not mainstream, and this is sort of therapy on the side. Have you heard arguments against psychedelic assisted therapy? I know that you're a practitioner within this area, but at the same time, are there arguments on the other side that you've heard, whether or not they're valid? But are there those who are opponents of psychedelic assisted therapy?
Yeah, so I don't know if any of you guys followed the FDA's approval for MDMA, that it didn't make it through. So that was a big part of it, was like, there's people, in the medical field as well as the therapeutic field, that feel like there's not enough evidence, because one is that we're trying to push the medicine through Health Canada or FDA, but then, with the protocol that they were trying to put through the FDA, at least for specifically MDMA, how do you govern the therapy, and how much of it is the medicine and how much of it is the therapy? And so I think that, there are people in the community that are like, we don't know, and it's not proven. And there's like this element, and it's really hard to explain. And if you've ever been fortunate enough to, like, watch a Hakomi demo or a Hakomi session, it's it's almost kind of like watching a little bit of an art form. And you're like, I don't know how you went from here to here. And now they're crying. And now we're in childhood. And now all of this, like, you're just, there is a map. And you know that this highly skilled practitioner is following a map. But I just think when you're working in non-ordinary states, it's also very intuitive. It's also very much like an art. It's also very much like a co-creation. And so I think those that are opposing it are like, what are you actually doing? Like, how do we know that this is actually what's happening? And because sometimes we don't know how this medicine is going to react with this human being, we could actually create harm. It could be too much. We could, like, we had a community of practice this morning with all of our therapists in Edmonton, and a client, one of our psychologists in Edmonton, said she had a client who had a psychedelic dose of ketamine, and it was terrifying. Like, she was like, just, that was awful. I never want to do that again. And that was, and she's reeling from that experience. But, so again, we're trying to conceptualize like what went on there, and this is a woman who has been an ER nurse for 30 years. Dissociation is how she copes with some of the traumas that she's seen. And, we put her in a medicine that blew her open, and it was hard. And so there are some people that, again, might go back going, well, if our ethical code is to do no harm, like, how do we know if we're harming or, so that's where it gets a little tricky, and I think that's why, we have these layers of like, first you meet our nurse, and then you meet our nurse practitioner or GP, and then consulting with our psychiatrist. And I mean, I think that for the most part, like, we're genuine, like, we're healthcare practitioners that are really wanting good results for our clients, like you would, and all of us that are in this field. But at the same time, like, there is a little bit of a wild card, which is the medicine. And we can create the bubble, we can create the setting, but once it's online, we don't necessarily know where it's going to go. And I'm sure there's a lot of people that are very uncomfortable with that because, when we do a Kobe session or you do breath work, which takes you into a non-ordinary state, you just open your eyes or you stop breathing. And yes, like, we can stop it with some of these rescue medications, but it's not the same, right? It's not immediate. And so there is a risk. That's the reality.
Well, yeah, and there's a risk for any therapy or any kind of like revisiting past traumatic events or so, of course, and maybe the risks are still unclear in terms of, who's going to experience what, and that's why it is still new. But maybe just for the listeners too, like unordinary states, you've mentioned that a couple of times, and my understanding of that is like, we have consciousness and we have awareness and we have certain kind of ordinary states that our brains, our minds are kind of in. And then for me, an example of unordinary state would be like under hypnosis, right?
Mm-hmm.
Like, so
Yeah.
you're still awake and conscious, yet you're in a different state. And maybe, yeah, just so the listeners kind of understand what you're meaning by unordinary states.
Yeah, yeah. So kind of more often referred to as like non-ordinary states is that it's, you know, one is what is, so another, again, a term that comes a lot out of the psychedelic research is what's called the default mode network. So it's the main organization in which the way that our neurology has mapped to create belief systems, schemas, understand, okay, when I drive my car, I don't have to think so hard, right? So again, these neural pathways that have really allowed us to function to some degree, like automatically, which can really be a gift. But then also sometimes those automatic strategies that we would have picked up out of survival, out of trauma, out of how to, all can also become automatic, but they are actually creating harm. So when we talk about moving somebody into a non-ordinary state, and again, sometimes people achieve that through meditation. You can use breathwork practices that can help that, with Hakomi, if you're doing it well, like you're achieving non-ordinary state. So it's what it is like pulling somebody out of those default ways. You're you're either through medicine, which we're opening up neurology. Sometimes through Hakomi, what we're doing is creating attuned attention to, and then all of a sudden things start to just peek through the default mode. All of a sudden you're like, oh, this like memory just showed up, or all of a sudden I got this feeling and I've never had this feeling before. So that is all coming out of the non-ordinary. It's the stuff that lies slightly below the surface, or really below the surface if we're kind of working with dissociation,
Mm-hmm.
that peek through. That, if you're doing your normal 9 to 5, Monday to Friday, it's not always in your consciousness, but
Mm-hmm.
sometimes that stuff that's in the non-ordinary, or that is just below the surface or really below the surface, is the stuff that keeps us stuck.
So then even like the conscious and the unconscious, right? Like the stuff
Yes.
that's kind of happening in the background that we might not be aware of, that could be in
Yes.
the subconscious. Again, these terms might be quite confusing to people. And just to add a little bit, because my background in Hakomi, like any experiential therapy, you're creating an experience, right, that someone has, and that has the possibility to shift some of the beliefs about themselves, about the world. Like, so there needs to be some integration that happens. So sometimes someone will finish a Hakomi session towards the end, and we're returning to the ordinary state, right?
Mm-hmm.
And they'll say, "What the hell was that?"
Yes.
And I can
Yes.
imagine that might happen in like any psychedelic or any of your therapy, your medicine work, right? Like, what the hell was that? And then there needs to
Yes.
be some time to make sense of what that was, right?
Totally. Yeah.
Yeah. Okay.
So our protocols always have integration built into the medicine work. So, there are clinics out there that just are medicine kind of molecule only. So, it's medicine, medicine, medicine. And, they kind of treat it as like a psychiatric medicine that in and of itself does have some therapeutic and symptomatic effects and rewards. But our model is not like that at the clinic that I work at. So we very much are like, we use the medicine to do the therapy. And so every time you have medicine, you always have an integration session afterwards. So to really braid back in some of that ordinary consciousness and meaning making, and, that really sophisticated prefrontal cortex that likes to be, wants to make maps and plan. And, so we need time for that. So at minimum, it's one. Sometimes clients need two or three if it was really big kind of piece that came through. It's like we want to integrate, and that's the part that, like, for me is really important, is again sort of being a psychologist working in this, to be a part of the clinic that I'm at that really values the therapeutic work and really values like how important it is that we're not just giving them these cool experiences or hard experiences and then not giving them the time to integrate what it means.
And as you're talking about that, you've actually said that I think 2 or 3 times in terms of like the actual work that's going on. And I have written in front of me as we at the beginning of our conversation, the title psychedelic-assisted therapy. And I've underlined
Yes.
assisted. Like that, that
Yes.
to me is such an
Yes.
important word. It's assisted. It's not just psychedelic therapy. It's just an
Correct.
assistance.
Yeah. And I think that's so important for people to understand. So, to answer a question you asked before, Andrew, somebody who would not qualify for one of our services or who would not be a patient of our clinic is somebody who's not willing to partake in the therapy. So, we do sometimes have people that are like, but I just want the medicine. They will not be accepted into our program and our treatment because, to your point, we are a psychedelic assisted therapy clinic, and the therapy is like highly valued in our clinic. And so they have to partake in the therapy.
My last question. You were talking earlier and it came up. I was thinking of like the police officers who go through their training and they have to get tasered before they're able to have a taser. Is that part of the program for everyone who works at your clinic, that they have to have experienced some form of this therapy or this medicine? I'm curious.
There are some training programs that have it really built right in. I did a bulk of my training through Therasil, and they do have
Okay.
experiential opportunities for therapists.
Yeah.
And when you sign on for that, you're also very aware that you are not doing it in a regulated setting. So you, as a clinician, can choose different trainings depending on what are some of their requirements. Um, but right now that I'm aware of, I don't know if there is actually any legal access other than a clinical trial. And I know at Messina at one point was trying to put together a clinical trial. And I know Therasil has worked very hard to try to put together like above ground, like learning opportunities for people that are going through training
Mm,
programs, but Health Canada just won't approve them. And so a lot of practitioners feel like it's really important for them to have an experience with the medicines that they're using. And so opportunities are available. They might not be the same opportunities that our clients qualify for because of the setting that they're coming to. But a lot of people have already had opportunities. I think that in some way, when you're drawn to this field, even as a clinician, it's perhaps sometimes because you've had experiences with these medicines in different countries or just through your own healing processes. And yeah, so I mean, again, I think opportunities are there. You just have to be comfortable. And nobody is, I will say this very, very clearly, nobody will force you. So, even if you're in a
yeah.
training program that has an experiential, and if you opt out of the experiential, that would be totally fine. Like there's nothing that's going to mandate that a psychologist has to take these medicines.
Well, that's interesting, maybe because it did cross my mind to want to ask if you ever tried it, but
Yeah.
obviously I didn't want you to put you on the spot because I mean, like you said, it has to go through approvals and so on and so forth. But it's sort of like when we're going through grad school, we're sort of told like, if you've never gone to therapy before, you should try it. You know what your clients are going through, so on and so forth. So doing the psychedelic assisted therapy, I mean, would clinicians know? And again, you don't have to answer this, but because how do you know what a client might be going through if one's never tried it?
Yeah. And like I said, I would say that you probably don't fully know. So the kind of the statement that we like to use is that everyone here has gone through their own healing journeys. However you want to interpret that.
No one's
um,
ever pushed it?
but when clients ask me directly, again, this becomes about disclosure. Like, if someone's going to ask me, do I have children? Am I willing to disclose that? And so, yes, I mean, the real answer is yes. Like, clients ask me, and then I say the honest answer. And you can tell they're like, oh, okay, so you get it. Were you scared? Yes. Like, there is a joining. That's like working with the body and then not knowing how to be in your own body. I would think it would be very difficult being a somatically practicing therapist that doesn't know how to inhabit their own body, right? And join in that with them. I kind of feel like this is similar, right? Like you can sort of like they're in it, but you kind of have your mind and your body have a felt sense of like, oh yeah, like they're sort of moving through this part of it. Or, and again, you don't want to project your own experiences, and we as psychologists know how to do that, but I just there is something about, yeah, like I don't know how to explain it any further other than somehow clients want to know. And you as a clinician, I guess, get to decide how much disclosure you want to have with it. And we all have our own, but I do find that clients feel settled and soothed when they know that you've had your own experience or own healing experience with some of these medicines.
Hmm. Yeah, I think this comes up in a lot of areas and even in marital therapy, right? It's like, well, are you married? And I'll often say, well, yes. And, my marriage could be very different than yours, right? Like, so I know something about being married, but does not mean that I actually know more about you. And so some people are more comforted that there's a common experience, but I also explain to folks that, not having the same experience allows me to ask different questions and be with you differently than someone who the risk of projecting and putting their experience onto someone else and assuming they know a lot about it. So, pros and cons. You could have yeah. And so I'll also say No, I won't. I'm done because I'm conscious of time. Yeah, I think Andrew, you usually do this, but we're so caught up in like following this. I think we could keep going again. We say this at the end
Oh,
of a lot of episodes.
yeah.
But in terms of takeaways, what are you walking away with, Andrew? What are you carrying with you as you leave this conversation?
Again, just another type of therapy, another option for clients, similar to learning about TMS a couple of weeks ago. Here's another form of therapy that we may not think of as mainstream, but that also doesn't mean that it's ineffective or wildly out in left field. In fact, just speaking with Priya today, just knowing that there are systems set up to ensure safety may not be 100%, and nothing is 100%, even other forms of therapy. It may not be 100%, but it's here. And a lot of research is being done on it. And I guess what I hope is that with various modalities of therapy, people will find something that works for them, whether it's your traditional 50-year-old talk therapy, or if it's an emerging type of therapy like psychedelic-assisted therapy.
Yeah.
And how about you, Dave?
Yeah, I thought piggyback off of that. For me, like I relate this to my own experiences in some way. It's that it's a form or it's a medication, it's a psychoactive medication that allows people to participate in therapy in a way that maybe they couldn't have without it, right? And especially, we're going to talk about trauma later on another episode, but like so often we avoid or we move away from those experiences or those feelings. And, I've had people later on come to therapy and be like, well, I was under the influence for the first 3 times because there's no way I could have came into your office without being under some influence, right? And I'm going, okay, maybe not ideal, but allowing people to access an experience of therapy that they might not be able to without some support through some kind of medication, regardless of what it is. That's how I see this. And so, yeah, correct me if I'm wrong, but that's what I'm walking away with as like, this can help you do the work.
And one more final thought too is a common factor here that I think is so, so important, as Priya mentioned, is that safety, comfort, compassion, and dignity towards people. Whatever therapy someone decides to go into, my hope is that that clinician, that clinic, that's what they're providing. And the form of therapy is, that particular modality is going to help you, but no matter where you go, you're being treated in the positive and correct way.
So Priya, I'm curious at the end of today, kind of, we do this, it's very organic. We don't plan out all our questions. And just as you've been present and engaged in this conversation, I'm curious what you're walking away with or what you want listeners to walk away with.
Yeah, I mean, I think I'm struck with like I feel like I just like scratched the surface. There's like so much more. So I think I would want listeners to walk away with, whether you're like a practitioner or you're kind of part of the general public, if you're curious, just start looking around, start researching, start whatever, because it actually has to feel right for you, right? Like kind of like what Andrew said, it's like, we encourage clients to try on different psychologists or therapists, like I have my standard speech to say there's so many of us, you have to find the right fit. I think this is a treatment that actually has to feel right too, because there's an element that requires some trusting and surrendering to the process and to the medicine and kind of what we're offering. And so it might not be right for everybody. And that's totally okay. But I think those that come to our clinic, they are looking for something different. They are looking for something alternative. And I think for those people, it's kind of like a little bit of a lifeline, like, oh, there's something else. Right. So they're quite grateful for there to be alternative, safe, regulated options for them. And yeah, but I agree, it might not be for everyone. So my what I would say and the takeaway is like, do some research, watch some Netflix documentary. Like there's so much out there. Talk to people, and yeah, just make sure it feels right.
Awesome. Priya, thank you so much for being with us today. This was so educational, so enlightening for me, and then, as I'm sure it was for Dave. And we could go on forever, but for today, we'll end it here. Again, thank you so much. Again, you can find Priya Bains at Messina, ATMACENA, and we're gonna put her socials up in the description as well for this episode. So if you have enjoyed this episode, if you're enjoying the podcast, please follow, like, subscribe, do what you need to do. Leave us a comment as well. We love to see what people have to say and about various episodes. And it just helps us, keep going producing these episodes. So thank you very much.
Take care.
Thank you.
Take good care.